Hello, thank you for sharing your time with us. Tonight I am thrilled that we are going to talk about fertility and cancer intervention and treatments with Dr. Constance. And so that is such an important topic because of all the early detection of cancer that's going on. There are so many more young survivors being diagnosed with cancer. And so we need to do everything we can to help you through the childbearing years. And so that is what we hope to do tonight, is to bring you some enlightenment on that topic. So first of all, I'd like to thank all of our wonderful sponsors for donating to Project Paint. Because of your generous donations, we are allowed to give you educational material like this and all the programs we do with Project Paint free for all of our cancer survivors, so we really appreciate that. Dr. Constance is going to do a PowerPoint presentation for the first half, and then we will do some Q&A. So please feel free to submit your questions through Project Paint, and that your questions will be in private that way. So before we get started, I would just like to say thank you very much. My name is Lori Buckley, and Dr. Constance is here, and she's very impressive, so I'm going to make sure I don't leave anything out and read this. She completed her medical school and residency in obstetrics and gynecology at the University of Kansas School of Medicine. She completed her fellowship training in reproductive endocrinology and infertility at the University of Michigan. She currently works at Heartland Center for Reproductive Medicine, where she serves as the Director of Fertility and Preservation, and she practices a full scope of fertility and reproductive care. She has also published research in her area of expertise, which is very impressive. For, how many years have you been working?
Just under 10.
Just under 10? So very nice. She has published research and has written chapter books on fertility and preservation for women with breast cancer. And she also holds the assistant professor appointment at the University of Nebraska Medical Center. So we are super thrilled that she is here with us. So I'm going to turn the evening over to Dr. Constance and let her wow you with her knowledge.
Thank you so much, Lori and Project Pink, for having me here. I'm really excited to be able to talk to everybody and get questions answered tonight. So we'll be going through just some kind of basic background information on the impacts of cancer therapy on fertility and strategies we have of kind of monitoring that and intervening if needed. So kind of the key objectives we're going to address are just kind of a review of natural fertility and reproductive function. The slides I have and the information I'm sharing are primarily related to female fertility and reproductive function, but acknowledging that breast cancer affects people regardless of sex and gender identity. And so we'll kind of hit on all of those key topics as well. We'll kind of describe how some of the various cancer treatments can impact fertility potential and reproductive function, and then talk about those strategies for monitoring post-treatment reproductive function and preserving future fertility when needed. So just some really basics of fertility, female fertility 101. The female reproductive tract consists of the vagina, the uterus and cervix, fallopian tubes, and ovaries. The ovaries really serve two key functions. So first of all, they make our hormones like estrogen that are important for bone and cardiovascular health. And secondly, they house kind of the resting pool of eggs, which are necessary for conception. So just a really kind of quick overview of the menstrual cycle and conception. Every month, the ovaries start with an activated cohort of eggs. Signals from the brain then select one of those to become what we call a dominant follicle, which grows and eventually ovulates or releases a mature egg. Sperm transport comes through the vagina and then through the cervix and uterus, and with the egg and sperm eventually meeting in the fallopian tube where fertilization happens. And then the embryo makes its way back to the uterus where implantation and fetal development occur. So both egg number and egg quality play a really important role in fertility, and abnormalities in either egg number or quality can have an impact on fertility and fertility potential. So one of the key things we talk about is ovarian reserve or egg number. And this is a term we use to describe kind of the relative number of eggs in an individual's ovaries. This is based on the fact that women are born with all the eggs we have for our lifetime. And those numbers go down over time, which is just what our bodies are built to do. And so that number that we start with and the rate it changes over time is really variable from person to person. And so then either starting with a lower than expected number or having an accelerated rate of decline can result in a low ovarian reserve. And this can lead to difficulty getting pregnant, as well as cause earlier than expected menopause, which is that time when we stop having periods and also signals the end of our ability to conceive using our own eggs. If we look then and focus on the portion of that last graph that represents a woman's reproductive window, or that time in which pregnancy is most likely to occur, we can see that natural fertility starts to decline around age 35, and then with a more significant decrease in reproductive function after age 40 due to that decrease in both egg number and egg quality. And so as I mentioned previously, all of those eggs available develop before we're ever born, and then are paused in that development until the time they're selected to be released and potentially fertilized by a sperm. And so the longer that they're in that resting or paused phase, the less efficient that machinery is when it gets reactivated. And that's kind of what we're talking about when we talk about declining or decreasing egg quality as opposed to egg number. So this decrease in egg quality or efficiency of replication of that genetic material leads to both decreased pregnancy and increased miscarriage rates over time. And so you can see that decreased pregnancy rate with the blue line and the increased miscarriage with that red dotted line. Unfortunately, treatments like chemotherapy can accelerate this process of egg loss, leading to infertility and early menopause. So chemotherapy is really successful at what it does, and we need it to be really successful at what it does. And that is by targeting and attacking those malignant cells in the body that are rapidly dividing and metabolically active, and eliminating them. The possible downside of these medications, however, is that they can't differentiate between those rapidly dividing metabolically active cancer cells and other cells in our body that are really active but just doing their job, such as those hormone-producing cells in the ovaries supporting that resting egg pool. So to the best of our current knowledge, once those hormone-producing cells in the ovaries that support growth and development are lost, we can't recreate them or grow new ones. And so the extent to which that damage from the chemotherapy occurs is dependent on the age of the person at the time of treatment, their ovarian reserve prior to treatment, as well as the medications that are used and the cumulative doses of those medications over time. All right, and so this is a really helpful table. It's from the Livestrong Foundation, so you can Google that and look at it yourself, but it breaks down kind of some of the more common chemotherapy regimens and their risk on fertility potential. And so they divide this into high, intermediate, and low risk categories. And there are separate tables for risks to men and women. So it's important to note that the percentages listed in this table are the risks of early menopause or complete ovarian failure after treatment. However, we know that a lot of women who don't go through early menopause may still experience infertility or subfertility. And so the rates at which this affects the ability to conceive in the future is even higher than those numbers that are listed. And if you look at the table, you can see kind of the most common categories of chemotherapy medications for breast cancer. You have the AC treatment, which is in the intermediate risk category, which means women who receive that combination of medications will experience early menopause, about 30 to 70% of the time, which is a pretty large range. Whereas some of the other chemo combinations in younger women under age 30 fall more into the low risk category. And so this next graph kind of is a representation of what we were seeing in that table more in a graphic form. So you can see in that dark blue solid line just the natural fertility decline over time that happens for everybody. In that dotted green line, I believe, is the low risk category, which is going to follow very closely to that natural fertility decline, but maybe experience menopause a year or two earlier. compared to that high-risk category, which you see takes a kind of an immediate decline. And so oftentimes those women will experience menopause very shortly after treatment. And then in the yellow line, you can see that intermediate category, which is where most breast cancer regimens are going to fall, which can have a wide variety of effects and timelines. And so that's where this becomes very individual and personalized. All right, and so then, although it's outside of really the scope of our talk today, I do just want to briefly mention, for any of you who may know someone who has been recently diagnosed and has not yet gone through treatment yet, that we do have options available for preserving fertility before undergoing cancer therapy, if there is time and the ability to do so. And so if anyone is interested in this, meeting with and talking to a reproductive specialist as early in the process as possible can keep open as many options as possible. All right, so then if we look at ovarian reserve testing, or how do we know what our individual egg number looks like? So one of the ways that we can evaluate this is with an ultrasound, to look at the number of follicles, which are these little fluid-filled sacs in the ovaries that house the eggs, which we can see and count on ultrasound. So that's one of the ways we can gauge kind of a current fertility potential. In addition, we can check some hormone levels, including AMH, which stands for anti-Müllerian hormone. That's a hormone that's produced by the support cells in the ovaries that surround those resting eggs. So the more resting eggs we have, the higher that AMH hormone level is. On the flip side, we can also look at another hormone called FSH, or follicle stimulating hormone, that's produced by the brain. And that's the hormone that talks to the ovaries every month to tell them it's time to select an egg to grow and develop. And that, as the ovaries start to slow down over time, can increase. And so all of those hormones in the ultrasound together give us a more complete picture of an individual's, current fertility status. All right, and so then this table shows kind of the normal ranges for those hormones, AMH and FSH, that we were talking about. And so again, as I mentioned, as the ovaries start to slow down due to low egg number, we see that AMH level decrease and FSH start to go up. And so watching those trends of decreasing AMH and increasing FSH can kind of help us know when we may need to intervene from a fertility preservation standpoint after treatment. And so we typically recommend waiting at least 1 year after chemo or radiation is completed before monitoring ovarian reserve, because there can be some transient decreases in those numbers during and immediately after chemotherapy. So we really want to give it that year time to recover before we start checking and possibly intervening. Depending on what those initial levels are, we will then typically follow annually or every year after that. But we may start checking more frequently if we start to see a significant change in those hormone levels, or if we may want to do additional investigation or treatments. And so then another really important question that's frequently asked is how chemotherapy or radiation may impact pregnancy in the future. And so we typically recommend waiting at least a year after completion of treatment before trying to get pregnant, in order to make sure that cancer is in remission, and to reduce any potential of risk of the treatment on a developing baby. The good news is that when pregnancy occurs at least 12 months after treatment, those babies are not at any increased risk compared to babies born to moms who have not experienced cancer treatment. Women with receptor-positive breast cancer may face an additional need to undergo several years of hormone therapy after initial treatment, which can further delay childbearing. And the positive study is currently underway, which is looking at the safety of interrupting that hormone therapy to pursue pregnancy. And so far, the early data has been promising that it can be safely stopped temporarily, allowing pregnancy to take place and then get back on therapy after pregnancy. Okay, so for individuals or couples desiring to conceive following cancer therapy, we have several options that we'll go through in detail. First and foremost, I do, want to acknowledge that having gone through cancer treatment in the past does not mean that you can't get pregnant on your own or without medical intervention. So if you are at a point in your life where you don't want pregnancy, contraception is important. And not everyone's going to need help from a reproductive endocrinologist or fertility specialist to build their families down the road. Although a history of cancer treatment is a risk factor for infertility, many individuals conceive without medical treatment. However, knowing that this can be a possible risk, it's helpful to seek early intervention if you are desiring pregnancy and are struggling to do so on your own. So one of the treatment options we have is hormone therapies to stimulate egg development and growth. So these can be either oral or injectable medications that are used to stimulate egg production for some women. For women who are not having regular periods but are not in early menopause, medications can be used to induce egg production and ovulation. For women who are having regular periods but are still having trouble getting pregnant, these medications can be used to stimulate the growth and development of more than one egg at a time, which just increases the probability in any given month or cycle of a good egg and a good sperm finding each other, resulting in a pregnancy. Because those medications can be associated with increased risks of multiples, it's really important that they are monitored closely by your physician. Another option we have is intrauterine insemination, which is the process by which sperm is placed in the uterus around the time of ovulation for fertilization to take place in the body. This procedure requires a sample of at least 1 million moving sperm. And so this can be an option for men who have reduced but not absent sperm production after treatment, and can be done with sperm that was frozen before cancer treatment. It can also be done with donor sperm for women who are single, women in a same-sex relationship, or women whose partners don't make sperm. IVF, or in vitro fertilization, is the process by which ovaries are stimulated to produce a large group of eggs all at one time, using injectable medications to mature that group of eggs. The eggs are then removed from the body and can then either be frozen as unfertilized eggs or fertilized to create embryos. And this is often the best option for men who have very low sperm counts or a limited amount of sperm frozen before cancer treatment. It can also be good for women who've had surgery to remove their fallopian tubes, or individuals who've failed less invasive treatment like the hormone medications and inseminations, or anyone desiring genetic testing of embryos. So once the ovaries have been stimulated, the eggs are collected from the body through a procedure called an egg retrieval. And this is typically done with anesthesia, so you're asleep and comfortable, and then a needle is passed through the wall of the vagina under ultrasound guidance into the ovaries, where they go into each one of those follicles or fluid-filled sacs one at a time. We drain out all the fluid, and then with the fluid comes the egg floating around in the middle. As that fluid is being collected, it's immediately handed off to our embryologists in the lab, who use high-powered microscopes to find the eggs and separate them from the fluid and other cells, so that by the time the procedure is complete, we know the total number of eggs that were able to be retrieved. Those eggs can then be either combined with sperm and fertilized, again to create embryos, or can be frozen as unfertilized eggs for future use. Ovarian stimulation for IVF typically begins with the menstrual cycle and lasts about 2 weeks. However, it can begin at any time during the menstrual cycle if needed due to time constraints. This is especially utilized when we're doing egg freezing before cancer treatment, when we might want to just get it done quickly so that treatment can start as soon as possible. For women with hormone-sensitive cancers, such as breast cancer, additional medications are used to keep those hormone levels low so they don't get any higher than they would in a typical menstrual cycle, so that we can make sure we're doing this as safely as possible. Additionally, ovarian stimulation can be done without the need to remove long-acting forms of contraception, such as Nexplanon and IUDs. For those who may be experiencing a decline in ovarian reserve after treatment but are not yet ready to pursue pregnancy, egg freezing is a really good option that can leave open that possibility of biological children in the future. And success rates now with frozen eggs are equivalent to those with fresh eggs. So there's no harm or detriment to freezing eggs. It is important to note that once those eggs have been fertilized to create embryos, both partners do have equal legal rights over the future use and disposition of those embryos. And therefore, because relationships can and unfortunately do sometimes change, if a woman is not wanting to use her eggs to get pregnant, right then, I typically recommend freezing eggs, regardless of her relationship status at the time that she's going through that treatment, just to leave open as many future options as possible. I will note, since a large part of our audience, I believe, is in Nebraska, that Nebraska is unique in that married partners do have legal rights over unfertilized eggs and sperm as well, although I'm not aware of any successful legal challenges to their use. So then once pregnancy is desired, a fresh or frozen eggs are fertilized with sperm to create embryos. And the embryo can then be placed inside of the uterus using a small catheter under ultrasound guidance, hopefully resulting in a healthy pregnancy. Success rates with this process depend on a variety of factors, and your fertility specialist will be able to kind of discuss those with you. So because, particularly with breast cancer, a lot of women have hormone responsive malignancies, that's been a really important safety concern for patients, physicians, and researchers. And so luckily we do have several studies that have looked at the safety of using these hormonal medications to stimulate ovaries in the setting of breast cancer. Multiple studies have now been published looking at both survival and cancer recurrence rates in women who pursue fertility preservation with ovarian stimulation and egg retrieval. And to date, all of these studies, including those in women with hormone receptor positive breast cancer, as long as they're receiving kind of simultaneous treatment with medications to keep those estrogen levels nice and low, all of the studies have demonstrated no difference in survival rates in women who undergo fertility preservation or fertility treatment compared to those who do not. So additionally, when embryos are developed in the IVF lab, we also have the ability to perform genetic testing if desired. And so this process involves taking a biopsy or a sample of 5 to 10 cells from the part of the embryo that will form the placenta, and then testing those embryos to look at the genetic information inside of them. And so this particularly can be done if one or both parents is a carrier of a known genetic mutation, such as the BRCA gene, if desired. So again, completely optional, but available if that kind of screening is something you would be interested in. And then I think it's also always important to note that there are lots of ways to build a family. And so when a patient's own eggs or own sperm are not able to be used, eggs or sperm or even embryos from a donor can sometimes be utilized. Likewise, if for some reason a woman is unable to carry a pregnancy herself, sometimes we can use a gestational carrier. And then finally, some couples will choose adoption or fostering as an alternative way to build a family. And so then understandably, one of the most important and most pressing questions I get when I talk to couples about all of this is the cost. And so these treatments can be expensive and unfortunately are often not covered by insurance, although we're working actively to try to fix that. For anyone with a cancer diagnosis pursuing fertility preservation or fertility treatment, there are some financial assistance programs available. The primary one of these is the Live Strong Foundation, which along with Walgreens can provide medications for free for those who qualify. And then clinics such as the Heartland Center who participate in the Live Strong program will then discount the cost of treatment, typically to about 1/2 to 1/3 of what that cost would be otherwise. And so then finally, I just want to leave you with some resources for anyone who would like additional information. There are a lot of great resources out there. One of the leaders in the field is the Oncofertility Consortium, which is an international network of clinics, hospitals, physicians, and other healthcare providers who collaborate together on research and best practices in order to improve fertility preservation outcomes. They have a lot of good resources on their website for families navigating what can really be an otherwise overwhelming process. So if you go to their website, you can search for fertility preservation specialists in your community, as well as access those resources. And so there's just kind of one final list of all of the resources out there. And with that, I would love to take questions.
Wow, that was great. My head's kind of spinning. I don't know about you guys, but I'm like, wow, that's a lot. So just because you just recently covered that one, so for one of the huge highlights is it's just really great to know that there's opportunities out there for women before they even start the breast cancer treatments, and that's really awesome. So do any of these programs cover the cost like before, or is there not? Is that a long process? Is that something that's even obtainable for somebody who's looking at fertility stuff prior to cancer?
Yeah, absolutely. You know, if freezing eggs or going through fertility preservation, either eggs or sperm prior to treatment, is always preferred if possible, so that we can kind of get those eggs or sperm before they've ever been exposed to chemotherapy and all of that. That process, you know, does take about 2 weeks, so it requires the time to do that. So if we have time before chemotherapy is going to be started, oftentimes, especially in breast cancer, if we're going to do surgery first and then chemotherapy, that time in between surgery and chemotherapy is a great time to also talk about egg freezing.
Well, only 2 weeks. That's not bad.
Yeah, it's an intense 2 weeks,
It's
a short 2 weeks.
That's really nice. One of the questions from a viewer is, will my oncologist bring up the option of freezing my eggs before treatment?
Oh, that is a great question, and it really, you know, varies pretty significantly. We were just talking about this beforehand. You know, the oncology team has a lot to cover, and this is an overwhelming, you know, process, right? You're getting that information. You're talking about treatments and surgery and chemotherapy, and then throwing in one more thing with egg freezing can oftentimes just feel really overwhelming. But I would encourage and empower anybody, you know, if your oncologist or your oncology team doesn't bring it up, ask. Ask for the referral. We can always just talk about it. Even if you decide not to freeze eggs beforehand, sometimes just having the conversation and kind of knowing what those options are allow you to then go into treatment knowing that you've made the best decision for you in that moment.
I would hope that in the very near future, that just becomes a normal thing that is put on the checklist because there's so many young survivors.
Yeah.
So that would be awesome.
That is absolutely our goal, is to get to that point.
Yeah, keep working on that. So with that being said, when they are referred to somebody, or if they haven't been referred and they're seeking their own, is there special credentials they need to look for? Is a cancer reproductive specialist different than a normal reproductive specialist?
Yeah, and that's a fantastic question. So you want to specifically look at someone who is a reproductive endocrinology and infertility specialist. So those are the people that have specialized training in IVF and egg retrievals and things like that. And that's where that Oncofertility Consortium website can be great, because if you put in your zip code or your state, it'll give you the specialists in your area who are, you know, trained in kind of that particular expertise.
Very good. Another question is, do you see a lot of complications with pregnancy if currently going through treatment?
That's a great question too. And so that's never an ideal situation, you know, pregnancy in the middle of chemotherapy. And so those are certainly can be complications. There are some chemotherapies that are risky to the baby. Sometimes we have to stop chemotherapy until we can get the pregnancy to a point of, you know, being able to deliver and then pick chemotherapy back up. So that's always a tough situation to be in.
If you have all your eggs prior to cancer treatment, what difference does it make that you wait that year? Because that egg would have been exposed to that cancer treatment anyway.
Yeah, that's a great question too. So in terms of just waiting, because the cancer, the chemotherapy, all of that can kind of cause the ovaries to go into a little bit of a self-hibernation as a mechanism of self-protection. And so oftentimes if we check, especially those hormone levels or do that ultrasound, it's going to look like the ovarian reserve is lower than it really is, because the ovary is kind of trying to shut down to protect itself. But we really do see that 6 to 12 months after treatment, those numbers oftentimes rebound. And so what we don't want to do is get too excited about falsely lowered levels and then do a whole bunch of expensive interventions that maybe you don't really need.
Yeah, good point. Should I have more observation if I am receiving treatment and just become pregnant?
Yeah, I think definitely make sure your oncology team is aware, and then you'll usually a high-risk pregnancy doctor will become part of that care team as well.
Do you have any recommendations for an OB that specializes in oncology?
Oh, that's a great question. I think really the ones who are the best specialists in that are the high-risk pregnancy specialists, because they're the ones that see those really kind of high-risk, complicated pregnancies. And so I would be looking for someone who's maternal fetal medicine or high-risk specialist.
What situations typically do get covered by insurance?
So that's really state dependent. And in our part of the country, in Nebraska, Iowa, really very few insurance companies cover fertility treatment, even when it's part of a cancer treatment or cancer diagnosis. A lot of times, if your insurance is through like a bigger national company like Google or Amazon or Starbucks, they do have fertility coverage. But for everyone else, unfortunately, we're really reliant on those grants and foundations to kind of help make this affordable.
And you gave them a very nice list of those that they can look at as well. So you recommended that an eval would be done on ovarian reserve, for the ovarian reserve, even for post-cancer treatments, even if they don't intend to have children because of bone and heart health. Can you explain a little bit more on that?
Absolutely. So, the ovaries, as I mentioned, have two big functions, and the one they get the most credit for is housing the eggs that we use if and when we want to get pregnant. But the other really important thing they do is make those hormones like estrogen and progesterone, which are really important for our bone and heart health. And so even for someone who maybe their family's already completed or doesn't desire children in the future, going through early menopause can still have long-term negative health implications for our bones and our heart and our brain. And so knowing if that process is happening and identifying it early on allows us to intervene in ways to kind of make sure you don't have 80-year-old bones in your 30s and 40s.
So would that apply just for the cancer survivors who go into postmenopause early, or would people who have already been through menopause and become breast cancer survivors, would that affect them in any way? Should they also get that checked?
Yeah, so for those that are diagnosed with cancer after menopause, they've probably have already had those conversations with their doctor hopefully about, whether hormones are appropriate or not in terms of protecting bones, or non-hormonal ways we can protect bones and heart health. So it's more important, I think, for the young cancer survivors who may not be thinking about that quite as much.
So I think that's a big key, and I've treated cancer patients for many years, and I have never heard of any of my patients who have gone into postmenopause early talk about somebody referring them to get their ovary reserve checked out. So I think that's really an important topic for everybody to learn today, that, hopefully that keeps them from being achy. And
exactly, yeah.
Like you said, old before their time.
Well, and I think that's too, where we sometimes have to advocate for ourselves is, when we go in to see the doctor, there's a long list of things that need to be addressed. And sometimes these are not the issues at the forefront of everybody's minds. That's where we really have to be our own self-advocates and ask the questions.
And that's nothing negative on the oncologist, because their primary job is to save your life and get rid of that cancer. And so that's the number one thing they're thinking of. Yeah. And if they went through every single thing at that first appointment, it would be just way too overwhelming. But
absolutely. And they're really good at what they do.
Yes, they're really good at what they do. So is infertility after cancer just about the eggs? If they receive like the donor, then going through pregnancy, is that easy for them? Or is there complications related to getting donors?
Yeah. So with donor eggs, so for those who can't get pregnant using their own eggs, the pregnancy shouldn't be any more complicated than it would be if they had been able to get pregnant with their own eggs.
That's great. So we mentioned that you have written some chapter books on fertility. Where would somebody find those books? What are their title? Can you give us any insight on that?
Yeah, so the chapter we wrote on breast cancer or fertility preservation for breast cancer patients is in, it's in an oncology handbook, and the name is escaping me, but I will get it to you so that you can put it on the website for people to look at. But it's primarily geared towards oncologists, with, just kind of a update on what the fertility preservation research and data looks like. But it's a fun resource.
Well, congratulations to you on that. Thanks. That's cool. How about the new laws that they're talking about for abortion and just the different laws? How does that affect any of the IVF? Is that affecting Nebraska ladies at all in any way?
Yeah, so I mean, that's such a timely question.
Yeah.
And it's still a little bit, to be seen. The concern is, anytime there are total bans, those can start to impact our ability to do IVF and egg and embryo freezing, and starts to get into disposition of embryos and things like that. And so that's that gray zone that we don't think about. I make babies, I build families for a living, and so it doesn't seem like that would have anything to do with abortion laws, but it's all reproductive medicine, and so there's a lot of overlap in gray zone, and these laws really can start to impede on our ability to treat people who just want to have families as well.
When you were doing your presentation, I was like, wow, that's a lot of heavy stuff. And then she says it so simply, I make families and babies for people. It's like, oh, wow, you have such a fun job. So how about the women who are taking hormone therapy and they have stopped having periods? Does that mean that they won't get pregnant?
Not necessarily. So if like while they're on tamoxifen after treatment, sometimes the periods will stop, but then may restart after treatment. That's where kind of seeing a specialist and getting that ovarian reserve evaluation can be so important to know what's normal and what's not.
So during that time, if they have a temporary, because it could be temporary menopause, do they still need to use birth control during that time period?
It's always, if you're not wanting to be pregnant, it's always important to be using some sort of reliable form of contraception, because even for women who are close to menopause, pregnancies can sometimes still happen. And so it's important to protect against that if that's not part of your plan right now.
And how long should they wait after treatment to see if they are fertile?
So typically we recommend doing that evaluation about 12 months after chemotherapy is completed. So that may be while on hormone therapy.
What if I'm newly diagnosed and I want to have children, what do I need to ask my provider? Is it simply just give me a referral to you? Or is there something else they need to be looking at first?
Yeah. I think, the key questions to ask are, what is my treatment plan going to look like? What are the risks of those particular medications or procedures on future fertility? And can I speak with a specialist to talk about those details in more, depth?
That's really simple. Can you say those one more time?
Yeah.
Because they're key.
Absolutely. So it's, what is my treatment plan? What is the potential risk of those treatments on future fertility? And do you have a reproductive specialist you recommend for me to go talk to?
So if you remember those three things, ladies, then you'll be fine. You'll be totally fine. That's all you have to remember is those three simple things. So I had read that tamoxifen may hinder my ability to get pregnant. And it can cause birth defects. Is that true? If so, are there other cancer drugs or treatments that could also cause birth defects, or some that I should stay away from?
So that's also a really good question. So the tamoxifen is a medication we don't want you getting pregnant while you're taking, if we can avoid it. So it's one of those things, again, contraception is recommended. If you're wanting to get pregnant in that time, that 5 years or so after treatment that you may be on hormonal therapy, that's a really important question to have first with your oncologist. We mentioned kind of briefly that positive study, which is looking at the safety of maybe coming off of tamoxifen after 1 or 2 years to have a pregnancy and then get back on tamoxifen afterwards. And the early data is showing that seems to be safe. But again, that's a very individual discussion. as a reproductive specialist, I certainly would want your oncologist on board before we made a plan like that. But kind of having that plan to kind of come off of it, get pregnant, and then get back on it is going to be the safest way to do that.
Is that the main cancer drug they need to be concerned about for that kind of thing?
Any cancer. So like the chemotherapies, I think, are the highest risk. But tamoxifen also, can be a risk if you were to get pregnant while taking it.
And the positive study you mentioned, who is doing that and where could people find information on that study?
So that, I believe, is a multi-center study. So there's kind of several academic centers involved in order to get kind of the numbers we need to see, meaningful outcomes. But even if you just Google it, you can get some kind of updated information. I don't believe the final paper has come out yet.
Okay.
So it's still a work in progress.
Another question is, will it impact my fertility or egg count if I have surgery before I see a fertility specialist?
So that's a fantastic question. With breast cancer, the surgery is not going to impact fertility at all because we're not talking about surgery anywhere near the reproductive organs. And so, like I mentioned, that time period between surgery and chemotherapy can be a really good time to look at egg freezing, or at least just getting a baseline ovarian reserve testing so we have something to compare to after treatment. Other surgeries, that may involve surgery to like the uterus or tubes or ovaries is going to have a bigger impact.
Sure. Do you recommend a supplement when going through menopause early?
So there are a lot of kind of data out there. It's all a little bit wishy-washy, unfortunately. Supplements, because they're not regulated by the FDA, are just not studied to the same degree that other medications are. If you're wanting to get pregnant but are in that kind of low ovarian reserve range, there are supplements out there, particularly coenzyme Q10, vitamin D, and DHEA, which may be of benefit. But again, that's something I would really kind of discuss one-on-one with your doctor before starting.
So most of the time when people are diagnosed with breast cancer, lots of times things move very, very quickly for them. It can be bing, bing, bing. So what if that happens and they have this little window? How hard is it to get in to see a reproductive specialist?
Right. So that can vary, obviously, from practice to practice. In my practice, we guarantee that you'll have an appointment with me within 3 business days of the referral coming in.
Do you sleep?
I do. But we know it's so time sensitive and it's so important that we make the time because it needs to happen. And we don't want to delay treatment because everybody's anxious to get treatment started right away. The oncologists, the families, the individual, everybody wants treatment started, yesterday.
Yes.
And so we don't want to cause a delay in that. And so you'll be seen by either me or one of my partners within 3 business days of that referral coming in. And then we can actually start the medications to start stimulation the same day that we meet if we need to.
Oh, wow. That just gives me goosebumps and warms my heart that you would get them in 3 days because, that's huge. So that says a lot about you. So thank you for that, doing that for our survivors. Appreciate it. Another question is, how will I know if I'm not going through the full menopause and if I can still get pregnant without seeing?
Yeah, so that, if you're having periods, even if they're, in that period before menopause, sometimes periods can either get shorter, closer together, or they can get spaced out. As long as you're still having periods, you can get pregnant. And so the definition of menopause is having gone 12 months without a period. Wow. So that if you're 11 months without a period, technically, it's still possible.
Okay.
Not common, but possible.
All right. I think another wonderful thing to know is, that there is help before the cancer treatment, and that's huge. So people don't have to fear about that. And now that they know that they can see you in 3 days, there's no worry about that either. So that's beautiful. Any other questions from us? No? Thank you. You've done just a beautiful job of sharing your heart with us, and you have such a smile on your face when you're talking about all this heavy stuff. So we know that you love it. So thank you for what you do for our survivors. We really appreciate it. Feel blessed that you shared all of this with us tonight, and I know our survivors do too, because it's really important to everyone here. So Project Pink's mission is from the moment of diagnosis to the end of life to bring you the tools and resources that you need to help strengthen you in your mind, body, and spirit. And we hope that we were able to do that a little bit for you tonight. Please remember to check out our website, projectpink.org. Sean, our amazing new director of programming, has got some awesome stuff lined up for us. Chef's Table is starting again April 5th. So please register online for that. We also have some new and exciting things coming up called Survivor Ignite. So look at the calendar for what's going on with that. So remember, ladies, anytime you're feeling defeated, and just know it doesn't matter the pace that you're moving, it only matters that you're moving. So keep moving, move forward with gratitude. We appreciate your time tonight, and we appreciate you. Thank you very much.
Thank you so much.